All right, at this time, I would like to introduce you to today's speaker. Scott Goodspeed has been president and CEO of 4 hospitals in 3 states and has deep industry experience and a national reputation in governance. His focus is centered on clarifying strategy, rapid deployment, culture change, and enhanced operational financial outcomes. A nationally recognized speaker, Scott has authored and delivered over 500 presentations to various professional associations and healthcare organizations on topics such as strategic planning, health industry trends, 21st century governance, constructive cultures, and the balanced scorecard. Scott's most recent book is titled Community Stewardship, Applying the 5 Principles of Contemporary Governance. He has recently written 2 articles on population health and reducing waste using comparative analytics. In addition, he is conducting research on organization and board culture, which will culminate in a book with a current working title, The Culture Checklist. Scott completed his doctorate in health administration and leadership with a dissertation entitled The Balanced Scorecard, Translating Strategy into Action. He received his master's degree in hospital administration from the University of Minnesota, where he was recognized for his academic achievement. Scott graduated magna cum laude from Ithaca College in Ithaca, New York, where he earned his Bachelor of Science degree in Administration of Healthcare Services. Now I will turn it over to Scott. Scott, are you there? Hello, Scott. One moment while I locate Scott. Scott, if you're on the line, please press *2 to unmute your line. Scott, are you there? All right, it looks like Scott is having a little trouble connecting, but he will be calling in and should be here in just one moment. Thank you for being patient, everyone. Scott, are you there?
Yeah, can you hear me?
Hi. I can hear you.
I'm not sure what happened last time, but let me get going. I called back in.
All right, wonderful.
Sorry about that, everybody, but I wanted to thank Kim and Leslie and Bethany and Terry Hill at the National Rural Health Resource Center. For those of you who are on the call, Wednesday we talked about how we're moving from fee-for-service to population health, and we talked a little bit about population health as defined as health outcomes of a group of individuals. It could be by age or disease entity. We also talked about understanding a new language, and at a minimum, we need to understand our service area as it relates to a 10-year insurance projection. And when we get done the call, any of you that want that for your organization, the service area, I'm more than happy to do that. Just as a reminder, we also talked about 1% of the population with the highest spending accounts for about 23% of the total population, and that the top 5% of the population is responsible for almost half of the spending. And that comes from the Kaiser Foundation. I don't know if there's anybody on from New Jersey, but I'm going to talk about the Camden experience. And when you hear a little bit about the Camden experience and healthcare expenditures, it's going to mirror the Kaiser Foundation experience, if you will. So the other thing I just want to mention is we did get a question from a physician at the end of the last call. We just didn't have time to answer, but it's an interesting question because it relates to population health and relative value units. And the question was, could you provide some guidance on how to start a new population-based management system from an RVU physician perspective? So what I basically said to him is relative value units as a payment model has been dropped for a number of primary care providers. And the best example I know of is Fairview Health Services in Minneapolis. In 2011, the health system dropped their relative value units as a payment model for primary care providers and established a compensation framework that ties 40% of the physician's payment to quality metrics and population health and 10% to patient satisfaction. So we didn't spend a lot of time talking about physicians or providers, but there's a way of tying in incentives on the provider side to population health. So today we're going to talk a little bit about using data analytics to manage population health services. And we're going to talk about some publicly available data. So sometime in the next week, I'm going to ask you all to jump on the CDC website. I'm going to show you some screenshots. The pretty interesting thing about this website and what they pulled together, it's been publicly available since March 10th, so just about a month ago, 2015. We're going to talk about how you can use analytics and claims data to better manage population health. I'm going to give you the experience of the Camden Coalition of Healthcare Providers as a case study. A group of providers, community members, school systems, social service agencies, other community agencies came together in 2002 to improve the health status of the population there. They also have a website, so if you Google that, you can find all of the data and the information that I'm going to share with you. I'm going to end the session. We're going to talk about chronic illness and population health priorities. We kind of started Wednesday with that, and then I'm going to suggest some action planning and next steps. And the other thing that I'll offer next week is any of you that want a 20-minute private conversation, consultation on population health and where you can begin, or you may have a specific question as that physician did about relative value units and how does that link to population health, I'm more than happy to do that and provide that. So this is I'll share with you the website, and we've got a list of references at the end of this presentation. But exactly a month ago, the Centers for Disease Control released their updated community health status indicators, what they call the CHSI. It's an online tool that produces public health profiles for over 3,100 counties in the United States. And if you're going to start with publicly available data, I suggest you begin here. So each of the profile includes indicators as it relates to health outcomes that describe the population health status of the county where you're located, talked about healthcare access, quality, health behaviors, some of the social factors, as well as the physical environment. And then you can get county peer comparisons as well as comparisons to the median numbers in the United States, as well as comparisons to Healthy People 2020. So this is a great starting place, and this is free. It's a free online tool. As I mentioned, you can look at peer county subgroups. You can look at it by census tract. You can look at it for subpopulations by age group, sex, race, ethnicity. The other thing that in this version, all the indicators, as I mentioned, are benchmarked against peer counties, the median of all U.S. counties, and Healthy People 2020 target. So it's a very good place to begin looking at data. This is the website that you can go to, and I just want to share. These are a whole list of other websites as well as indicator initiatives that they reviewed. If you have time, I would suggest that you at least, at a minimum, visit the county health rankings and roadmaps as well as the U.S. health indicators. And if you haven't been on the Healthy People 2020 website, that is another very, very good source. So the framework that the CDC used is, it's a little bit old. It's 1990, but it's still very relevant today, and it's called the Evans and Stoddard Framework for Determinants of Health. And if you look down at the bottom pink, purple box where it says well-being, basically the model that the CDC is using has a hypothesis that there's certain things in our social environment that may lead to individual behaviors. There's certain things in our physical environment that may either promote or enhance disease. When we talked about blue zones on Wednesday, we learned that the research that came out of the National Geographic work that Dan Buettner did, that about 25% of our genetic makeup predisposes us to certain chronic diseases and other illness, but that's not the majority. The other 75% is determined in this model here. So the framework can be used to promote healthy communities. They look at social factors, physical environments, health behaviors, health outcomes, morbidity, mortality. And when you go to the website, you can see all of these indicators, and you have indicator definitions. It's probably obvious, but this website does not have a category of genetic endowment because genetic factors are not typically modifiable. So when you go into the website and you type in your state and the county you're located, you're going to see a table like this, and it's basically a summary comparison report, and it gives you an at-a-glance summary of how your county compares with peer counties for a full set of indicators. Now let me just tell you what the primary indicators are, and I suggest when you go to the site, you actually can click on primary indicator, and you can see what the indicators are. So the indicators are grouped in a bunch of different categories. For example, there are indicators related to mortality. So if you want to know mortality in your county by age, sex, by ethnicity, by race, you can look at cancer, diabetes, stroke, motor vehicles. If you want to better understand morbidity in your county, you can look at things like obesity and diabetes. If you want to understand healthcare access and quality, you can look at primary care provider access. You can look at the uninsured. You can look at cost barriers to care. If you want to look at social factors, you can look at things like poverty, violence, children with single parents. If you want to look at healthy behaviors as a primary indicator, you can click on that, and you can look at smoking, things like teen birth, physical inactivity. So there's a lot of information that is behind this. Again, the comparison that I'll show you, and I live in Rockingham County in New Hampshire, so we're going to look at my home county, if you will. And again, this is publicly available data, and we'll see where either my county does better than the peer group, better than the U.S. median, or where it does moderate or worse. This is just some additional information that you can find on the site. There's a lot of detailed information here. I'm not going to go through it, but I would just mention that there's an indicator description. So if you're presenting this to your board of trustees, a medical staff leadership group, there is the indicator listing, a description of the indicator, the source, the methodology, the year that the data is available, and sometimes that can be very helpful for an internal or an external presentation. So this is my home county, Rockingham County in New Hampshire, and what you're looking at is this comparison report at a glance. So all of these things that you see in the boxes, motor vehicle deaths, stroke deaths, those are all what they call primary indicators. And you can see for motor vehicle deaths and stroke deaths, my county does better than its peer county. So I'm probably, from a population health perspective, I'm not going to be so concerned about those kinds of causes of death. When you go to the middle box where there's that moderate category, I'm a little more interested in things like chronic lower respiratory disease, coronary heart disease, diabetes, and those kinds of things. So now I'm beginning to get a sense of where I might look, at least with this publicly available data. When we look at morbidity and I look at the moderate category, now I'm very interested in diabetes and obesity and adult overall health status. If I go over to the right where I'm worse, you can see it's cancer and older adult depression. When you look at healthcare access and quality, there are some issues within my county related to primary care provider access and the uninsured. So what does that mean in terms of population health and visits to hospitals or visit to hospital emergency rooms? You can also see that when we look at healthcare access and quality, there are some cost barriers to care. So I'm very interested in that too. When we look at health behaviors in the moderate range, my county, there's an issue with adult binge drinking, adult physical inactivity, adult smoking, and teen births. And we know some of those things are behind the leading causes of death, so that may go on my population health list agenda. And then finally, when we look at some additional primary indicators, when we look at the social factors, we look at the number of children in single-parent households, and I'm going to talk about a risk assessment. I think that's my last slide as it relates to kids and some of these other kind of indicators. On-time high school graduation is an issue, poverty, violent crime, high housing costs. And then if you look at physical environment, if you go to the right, the far right-hand side, you can see there's an issue as it relates to limited access to healthy food. And we saw that obesity in my county was a little bit of an issue. So we can begin to get a sense of kind of where we're going to begin to look and what kinds of indicators we need to push on and set priorities for. These are actually duplicate slides. The other thing, if I'm interested in diabetes deaths in Rockingham County, I can get the rate per 100,000, and you can see that my county is below the U.S. median. I'm also below, you can see that dotted line. That's the Healthy People 2020 line, if you will. The other thing that I didn't do here, you can get a description of what this means. You can look at census tracts and you can look at associated indicators here. This is the percent of adults living with diagnosed diabetes in Rockingham County at 6.5%. You can see I'm a little bit less than the U.S. median. When we look at the percent of adults who report smoking cigarettes in my county, it's 16.1%. So even though it's a little bit less than the U.S. median, it's greater than the Healthy People 2020 target. And again, I mentioned the Healthy People 2020 website. If you want to set targets in your community that are consistent with some of the national indicators, I would use the Healthy People 2020 targets. This is the percent of adults who didn't see a doctor due to cost in Rockingham County. You can see it's 9.8%. It's less than the U.S. median, but it's hovering right around the 2020 healthy people target. And then I think I've got a couple more. This is the percentage of adult obesity for Rockingham County. It's 24.7%. You can see it's less than the U.S. median, but I'm in this category of this kind of moderate category, trending to worse. So this is probably going to be on my list in terms of one of the population health initiatives. So I would encourage you, and you can spend hours on that website. I would encourage you to, for your state and your county, to look at your indicators, begin to set some priorities using that website. And now we're going to go the next level down and dig a little bit deeper. So we talked about publicly available data. Now I'm talking about data that's privately available. However, as we go through this part of the presentation, you're going to see some statewide initiatives as it relates to all payer claims databases. So now we're talking about analytics and claims data, and I'll tell you specifically what that is. So there are all payer claims databases that offer all of us a chance to look at information they need to evaluate cost, quality, incidence, prevalence of disease. And right now there are more than 30 states that actually have implemented all payer claims databases. And I'll show you a map, and you can see if your state is one of those that is participating. Here are 2 additional websites. I would check those in the next week or 2. And the second website is a very good source because it talks about how you can realize the potential of claims data databases and how you can come up with a plan to report those data publicly as well as within your organization. So this is a 2014 map as of March 2014 with the all-payer claims database, and you can see where you see the gray. Those are states that have no current activity today. The dark blue, that's where there are some existing initiatives. So for example, in my state of New Hampshire, claims data is available. Where my office is in Portland, Maine, claims data is also available. So you want to go to this website and you can see what's available on a statewide basis. And typically, this is the kind of information you're going to find here. And everything is encrypted, so it's encrypted social security numbers, patient identification, of course, is encrypted. You can look at types of products. You can look at patient demographics. You can look at diagnostic categories. You can look at procedures. You can look at health plan payments. You can look at facility types. You can look at revenue codes. On the right-hand side are the kinds of data elements that you're typically not going to find in this database. Now let me make a distinction between this, which is publicly available, but it's private claims data, if you will. Understand that within your organization, you have access to through your electronic health record, your own claims data. So that's another component, but I'm not going to spend a lot of time talking about that. So here's one. This is the state of New Jersey, and this is how they used it in the Camden Coalition of Healthcare Providers, and you'll have their website. They started in 2002. A group of providers came together and they decided that what they wanted to do was to improve the health of Camden residents by increasing capacity, quality, accessibility of the city's healthcare delivery system. And you're going to see some screenshots which came from their website that are pretty amazing, because one of the things that they decided early on is that they would be data driven. And I'll show you what that specifically means. So this coalition of providers, so it was hospitals, it was other healthcare organizations, a lot of the social service organizations, government, and of course residents and the community came together in this very comprehensive initiative. And they did something called hotspotting. And for those of you who saw the 60-minute segment, it was on about a year ago, January, February 2014. They actually had a segment on hotspotting and the use of big analytics, if you will. So hotspotting is a data-driven process for the identification of extreme patterns in a defined geographic region. It could be a county, it could be a city, it could be a building. And I'm actually going to show you some of the buildings in Camden, New Jersey that represent populations with the highest use rates, the highest falls. So we can use this hotspotting technique to determine what the interventions are, so we can understand actually where these patients are, what their needs are. We can look at effective and ineffective utilization, all to reduce costs and to improve quality. So the group came together and built a claims database. So it's a claims database, looked at diagnostic, financial, operational, standardized the data. They looked at behavioral information and put together probably what I feel is one of the most comprehensive claims database that's actionable in the United States. So they had all of the social service organizations come together, all of the health plans, all of the healthcare providers, and they actually built an integrated data warehouse, which is represented down in the right-hand side of this graphic. So it just was not only hospital claims data, it was comprehensive claims data. And so we saw this analysis with the Kaiser Family Foundation, and this is what showed up in the Camden Healthcare Coalition, and this is their cost curve. So when they looked at all of the claims data, they found out and determined that 1% of their patients, okay, equals about 30% of the receipts or of the hospital spending. Again, 1% of the patients represent 30% of the spending. And we talked about that when we looked at some of the national data last time. What's also very interesting is 10% of the patients represent about 74% of the receipts. So if you actually look at the numbers here in Camden, that represents about, I think it was about 5,100 patients. So when we talk about population health, now let's focus in on those 10% of the patients that represent most of the cost in the system. And so let's begin to think through the characteristics of those population. Let's begin to think through where they reside, and you actually begin to come up with some pretty amazing things. So this is an example of hotspotting, and this is in Camden, New Jersey, where it's a little bit difficult to read, but you can see where these yellow lines go represent several buildings in Camden, New Jersey, and they annually generate $1 to $3 million in hospital costs, just those buildings. And so 6% of the city blocks account for 18% of the patients and 37% of the receipts. So now with the hotspotting and looking at the map, we know exactly where to go. We may not know what's going on yet, but we will. Now, when we want to understand Camden's high utilizers, the average age is 57. They typically have greater than 5 chronic conditions, and that represents 1% of the population. It's difficult to see the 2011 averages, but they typically spend 54 days in a hospital, $673,000 in discharges, and typically spend 4.5 ED visits, and as I mentioned, 54 days in the hospital. And you can see their top diagnosis, and again, you're getting that from the claims data. So these patients either have some type of respiratory issue, chest pain, abdominal pain, and you can see the list. So that's where we're going to begin to focus. And this is a little more specificity in terms of this patient population. They have 2+ hospitalizations in 6 months, 2 or more chronic conditions, 5 outpatient medications, and there are some different indicators that they looked at as it relates to social instability. This is very difficult to see, and I apologize, but this is hotspotting, and what we're doing is actually looking at fall visits for the 60-plus population. And the way that they did this analysis is they actually looked at several buildings in Camden, and while this is difficult to read, for each building it's got the number of falls, the total number of receipts, or the total spending related to those falls. So one of the initiatives that you find in Camden is a fall initiative. If you look at the right-hand side, they're looking at indicators such as assault victims, total assault visits, gunshot victims, and while the Camden graphic is a little small, you can see where they hotspotted that, and they know they have some specific issues. So that's the Camden project. They offer to have speakers to come out on site. They're still in operation. They have, they take residents and interns, and so this website, again, is another very, very, very good source as it relates to population health. So I want to come back to chronic disease in America, and I'm going to wrap this up in about 10 to 12 minutes. So we talked about on Wednesday how more than 125 million Americans suffer from one or more chronic diseases, and 40 million are limited by them. The annual spending is nearly $1 trillion, and there are significant advances in care, but we also know 1/2 or more of the patients still don't receive appropriate care. So there are gaps in the quality that lead to thousands of avoidable deaths each year. The one thing that I didn't spend any time on that we should pay attention to is the whole issue of readmissions and the ambulatory sensitive conditions, particularly as it relates to those potential patients over 65, because those admissions for those ambulatory sensitive conditions are avoidable. And you have all of that data in each of your organizations. So the other thing that we know that best practices could avoid about 41 million sick days and more than $11 billion annually in lost productivity. So patients and families increasingly recognize that there may be some gaps in their care, and we've talked about those chronic diseases, and this is where I think we need to focus: heart disease, stroke, cancer, diabetes, obesity, and down the list, because we know a lot of those are preventable issues. If we think about Medicare beneficiaries, and again, this is where we started the conversation. So if you think of your service area and all of the Medicare beneficiaries, whether they come to your organization or whether they go outside your service area to another organization, this chart shows the number of chronic conditions by percent of beneficiaries and the percent of expenditures. So those Medicare beneficiaries that have between 1 and, let's say, 7+ chronic conditions represent about 63% of the beneficiaries and about 95% of the cost. So naturally, we want to understand this population, particularly as it relates to greater than 1 or 2 chronic conditions, because we also know that that's where most of the healthcare spending is going. So 7 of the top 10 causes of death in 2010 were chronic diseases. 2 of those chronic diseases, heart disease and cancer, accounted for nearly 48% of all the deaths. Obesity is a serious concern. More than 1/3 of the adults, of about 78 million people, were obese, and nearly 1 in 5 youth aged 2 to 19 was obese. And again, you can get this all on the CDC website for your county. Arthritis is the most common cause of disability. We may want to look at that as a chronic disease. And then one of the bigger ones is diabetes, of course, where the leading indicator of kidney failure, lower limb amputations, and other things that cause various injuries, including blindness, relates to diabetes. Finally, I want to show you, this is MPHC is Martins Point Healthcare. We're doing some work with them today. And this is one way of thinking through, if you want to, an approach to understanding those high-risk cohorts. This is one approach with a number of indicators. Understand, I'm not a clinician, I'm not a physician, but I'm going to walk you through this. So first of all, we want to understand who are our high-risk patients. Those pediatric population, those young adults, older adults, elderly, and then, as I mentioned on Wednesday, those in end-of-life situations. So here are some things to think about. This ASQ3 below cutoff in greater than 1 area. If you Google ASQ, you'll understand that's the #1 developmental screener to detect early delay in children. And so they've got a criteria here that they want that number, the ASQ3 below a cutoff score, but this could give you an indication of children that might be at risk. The second indicator that they use is this ACE score greater than 6, and there are 10 types of childhood trauma, things like divorce, death, an alcoholic parent, and this score, based on these indicators, they want to look at these kids who are at risk who have a score greater than 6, because we know those kids may, or most likely, will fall into a high-risk cohort. This addiction risk assessment includes things like tobacco and alcohol, and an assessment where there are a score greater than 8. Again, that falls into a high-risk category, a high-risk population, if you will. The HbA1c is a diabetes predictor, and so they're saying with a score greater than 9, those are the kinds of patients that we're very interested in following. The next one, the RAF score greater than 3, my understanding is that's a protein expression that correlates with breast cancer metastasis. So they're looking at a score greater than 3, and they're interested in that high cohort of predominantly women in that category. And then, I don't know where this question came from, but it was what they call the positive surprise question. So if you go back in and ask your providers, so your physicians, nurse assistants, your PAs, and you ask them the question of who are your high-risk patients that may die, pass away in the next 6 months, they're going to give you the list. Those patients fall into a high-risk cohort too, and that's what we call the surprise question. And then most of you, if you want a prior WebEx, you've seen this population health framework. You may have seen Eric Schell or others from Stroudwater spend about an hour and a half or 2 hours to walk through this. I'm not going to do that, but if you want a copy of this presentation in a PDF format, I'm more than happy to send it. But one very good place to start with a board of trustees, a medical staff leadership group, an executive management team, is to walk through what we call this shaky bridge framework, if you will. Because one of the things that we do here is we specifically walk through the 8 or 9 initiatives that will eventually help you move from fee-for-service medicine into a population health framework. And some of you may have heard this, and again, we're more than happy to make this available to you. And then I think I've got one final slide in terms of action planning or next steps. Typically consistent with a population health initiative is to spend time, and you all do this now, understanding your operations, understanding kind of all of the quality metrics, all the patient safety indicators, where you are financially, and to get as much improvement as you can in that one big bucket. The other thing that's absolutely critical when we talk about population health is primary care network alignment. You want to make sure that you're working effectively with your primary care physicians for a lot of the reasons we talked about as it relates to population health. But they're actually the core as it relates to a population health future. The third thing I think you want to think about is you've got 5 or 6 data sources now you can go to begin to look at population health analytics and improvement initiatives. Again, I would try to understand what your 10-year insurance of uncovered lives are, and I think that was about the 4th or 5th slide that I went through on Wednesday. So you want to understand where you are today, where those insurance covered lives will be in 2024 by payer category. You want to understand those high-risk, high-cost patients, and as I said earlier, I'm more than happy next week if you want to set up just a 20-minute consultation to look at some of your own data or talk about where you begin. I'm more than happy to do that. Finally, the integration of your population health strategy into your hospital strategic plan, so it's well understood broadly throughout the organization. I think that's, if you haven't done that, I suggest that you do that. And you can see there's a little bit of an inconsistency here, so we'll move the kind of the health checklist consultation to 30 minutes. And that's it. But again, what I would suggest is you've got a lot of material, you've got a lot of resources. We'll send around the list of materials, but I'd spend a number of hours going to the various websites. I recommended the most recent Blue Zone books. I'd get a copy of that. I mentioned Al Lewis's book earlier, and I'd at least get a copy of that for your library. So with that, that's a lot of material, a lot of information, and again, the access to the CDC website is free and pretty comprehensive. I'm more than happy to answer any questions now.
Thank you, Scott. Jermaine, was your question about service area answered? Scott, Jermaine Stefanak had a question. He had written in the chat box, please share service area information. To unmute your line, press *2, or you can type a question or comment in the chat box. Amber Rogers had a question. Is there a publicly available Medicare claims data?
We, at Stroudwater, we own all of the Medicare shared savings data. Sometimes that's available. So for example, if you're into a federal grant, which we had in Montana, all of the Medicare claims data for that innovation project was available at no cost to those 25 critical access hospitals. There's a lot of good Medicare claims data that's available, but it doesn't have all the data elements that you typically want and need. I would also check the state that you're in to see if it's one of those states that has all payer claims data, because that will also include Medicare claims data.
Great. It looks like you answered Amber's question. Does anyone else have a question? It's *2 to unmute your line, or it looks like Tim Williams is typing a question in the chat box.
Yeah.
And I did list the references in the little references box on the screen. So you can use the scroll to see all those references down there.
Okay, yep, I see those then. That's good.
Tim wants to know, how can we best communicate population health needs for those hotspot zone communities without stereotyping?
It's a very good question. It's a very good question, because if you go back to the Camden example, sometimes what they found were kind of the highest spend, if you will, related to poverty, related to lack of access and health insurance. But what I'd suggest is that when you do the hotspotting, you're looking at hopefully claims data, which you have internally, maybe publicly available claims data, as well as some of the data that's coming from the CDC, and it is what it is. So I mean to say that a population health initiative, in my experience, is most useful, and where you may get better results is where you have a broad community initiative. Because, for example, when we were in Montana and looked at all of the Medicare claims data, and we hotspotted that, so we overlaid things like diabetes with obesity, with chronic heart failure, and we were looking at some communities, some counties where maybe stereotypically you could say, boy, if you look at the median income or if you look at access to care, but that wasn't the point. Okay, the point was, when we did the hotspot, is we're looking at high cost, high risk, and in fact, how do we reduce? Okay, whether it's the fall rate as we saw in the Camden example, or whether it's those high expenditures, if you will.
Hi, Scott. This is Bethany.
Hey, Bethany.
Hey, at first glance, I bet there's a few small rural hospitals out there thinking, oh my goodness, with all their hats that they're wearing, multiple hats to do all the jobs that they're doing. This just might seem a little overwhelming, I'm sure, at first. But maybe we could give them at least one place to start. I mean, why couldn't they just even start with their own claims data, or what would they have in hand? What would you suggest as a simple one place to start looking at targeting that 1% or that 10% that really impacts their overall operations anyway?
I do three things. I look at my internal data to see who the high cost spenders are, and we know what that category is going to look like. It's going to be, a lot of the patients who are over 65 with multiple chronic conditions. So I would try to identify that internally. The other thing, I think a simple framework, because you're not going to go after everything. So the Martin's Point Healthcare framework, I think, is a very good starting place. And I wouldn't have any more than, they've got 1, 2, 3, 4, they've got 6 indicators that they're going to be tracking there as it relates to those high-risk cohorts. So I develop a simple model. And then again, if you're in a state where you have all-payer claims data that's available, I would go to that site too. So I go to the CDC site, I go to the all-payer claims data site, I look at internally what you've got and develop a simple model. Now, Bethany, here's the other thing I'm thinking, because I understand how overwhelming this can be, and I'm wondering if, as a result of the population health series that you have offered, if we could come up with a simple couple 4 or 5 page guidebook in terms of where to begin. That it's something to think about.
I think that would be very helpful, beneficial to both the rural hospitals, their communities, a simple place to start, something to follow, 1, 2, 3. I think that's also something the state offices could benefit from and they could use to help their communities. So it's a good idea. I'll follow up with you.
Yeah. And the other...
I'm sorry. And I'd like to hear from the people who are on the call. Do you think that would be beneficial to you? What do you think that we could have on our radar to help make it a little more easier to understand step 1, 2, 3? Sorry. So if they would have typed in some of their answers or questions, that would be great. Scott, I'm sorry. Go ahead.
Looks like Joyce is typing. Definitely for Arizona, she said.
And it's *2 to unmute your line if anyone wants to speak.
Looks like you have a question from Tim about the hotspot.
Okay.
Actually, Tim Williams, how we can best communicate pop health needs for hotspot communities without stereotyping, and Scott already addressed that question. Was there another one that you saw, Bethany?
Nope, sorry about that. I just got confused. Thank you.
The other thing, I'm looking at the future conferences, and there's one May 22nd on patient-centered medical homes. I would attend that one. I think everyone needs to understand what those are and their value moving forward.
Great.
Any more
You
questions
can
or
register
comments?
for that right on our website. All right. Well, thank you, Scott, for a great webinar series. The playback of today's webinar and last Wednesday's webinar will be available on our Help Webinar playback page later today. I'll add it. Please take the short online evaluation for this webinar if you'd like to receive 1 hour of pre-approved ACHE of qualified education credit. You must complete the evaluation and indicate that in question 2. To take the evaluation, please follow the link on the screen. Please join us April 22nd and 24th for our next Help Webinar series on contract negotiation, tips for a value-based payment future, featuring Marty Ross. To register for any of our upcoming webinars or PMG calls, please follow the link to our Help Webinar registration page. If you have any questions or comments, please contact me at the email on the screen, and I hope to have you on future calls. Thank you, everyone.
Thank you.